A lot of technical support is going on to get this lecture sorted. So anyway, so we are doing gastrosystems. So today's topic is cholestatic and biliary diseases. So it's got a few diseases to cover. So I'm going to skip through some slides. We're going to go through the slides. We're going to go through the case, and we will investigate it, and then we will. Huh? हाँ. अब क्या करें? देख फैल जाएगा. एक मिनट. उसे क्या अब देखें? So a lot of technical issues are going on. Uh, you are not seeing the screen, which actually I am seeing. So I think all the slides are on the screen for you. I'm just trying to sort it out. Uh, just bear with me. So our IT experts are trying to do something. So I think he is just giving me a green signal to go ahead. So you will start with the cholestatic and biliary diseases. So first of all, we're going to go through one case study. As you can see, the 2 years old woman with the two children came in with complaints of right upper quadrant pain, epigastric pain. It's mainly happens when she eats food and persisted with some vomiting. She vomited bile. She had a previous history of this episodic radiating pain to the right upper quadrant for 1.5 weeks. The episodes were triggered by the rich fatty foods. So if you see the differential is here is quite obvious that you may have a gallbladder disease, or you can the peptic ulcer disease, adrenal ulcers can present the same type of picture. Pancreatitis remains in the differential. So investigations showed the white cell counts were raised with 88% neutrophils, showing that some infective process is going on. The bilirubin was slightly raised as of AST as well. The lipase was normal, so mildly raised bilirubin with a raised AST and neutrophil count predominance. Ultrasound reveals a gallstone in the neck of gallbladder. She also had a family history of gallstones. So once we had a case, we did some blood investigations, and then we did some imaging studies, which includes the ultrasound scan, which confirms the gallstone. So it's someone who is 42, female, has a positive family history, has two children. We haven't mentioned about the BMI, but that would be interesting as well, because we expect the BMI to be high in this patient. So she was given some pain medication, analgesia, and some antiemetics. Morphine remains the cornerstone for the analgesia. Ondansetron, she had, this is an antiemetic, domperidone, and 1 liter of normal saline. But these patients do have dehydration. She was given third generation antibiotics and a flagyl metronidazole. Metronidazole probably given because of the abdominal source of infection. So management continues. We refer the patient, and she was scheduled for elective laparoscopic pleurisectomy. An ERCP and sphincterotomy was performed as well. The common duct was widely dilated without evidence of intrahepatic dilatation and no stones. So up till now, we have someone who had a gallstone, and we were trying to make sure that the common bile duct is not obstructed and there is no intrahepatic duct. There was some sludge in the duct which was removed by doing ERCP. The laparoscopic polycystectomy was performed a month later once these episodes were resolved. And the gallbladder, when it was taken out, it was distended, and it does show some acute inflammation and edema. So here are the 2-3 pick-up points that diagnosis-wise, ultrasonography was the most important diagnostic modality to diagnose this patient. LFTs give you an idea about whether there is some evidence of extra intrahepatic duct dilatation or there is a stone in the common bile duct. So ERCP and sphincterotomy was performed in a view of that. So general surgeons did not did an emergency cholecystectomy. They scheduled the patient for an elective laparoscopic cholecystectomy, and which was performed a month later. So gallstones. So let's talk about the gallstones. What are the gallstones? The small pebble-like substances, multiple, they can be multiple, they can be solitary, they can occur anywhere in the biliary tree. They have different contents, and depending on the contents, their appearance is different. So here are some gallstones you can see, bag full of gallstones. So most common disorder of the biliary tree is the gallstones. They're very, very common. So they're classified into 3. So some are clustral stones, pigment stones, or mixed stones. So clustral stones, I believe, are the most common stones. The pigment stones, let's talk about the pigment stones. You can see these black pigments. They're small, they're friable, they are irregular, dark, they are made of bilirubin and calcium, and therefore less than 20% of the stones. So they're mainly made up of calcium and bilirubin. So they're small, irregular, friable stones. You can see it. So composition and risk factors. Let's talk about the compositions of stones. So and the risk factor, as you can see, so the compositions, they're black colored stones. They are mainly of calcium or calcium phosphate or carbonate or bilirubin stones. If they are brown in color, they are mainly of calcium stones, and mainly of cholesterol stones, with some are calcium and calcium bilirubinate. The risk factors for bilirubin stones is as hemolysis. If more hemolysis happens, the more bilirubin will be released. Age, cirrhosis, and resection diseases. And the brown, which are the cholesterol stones, the risk factors includes infected bile and if there is a biliary stasis. So if the biliary stasis is going to be infected, once it's infected, it's going to be a cholesterol or calcium permeate stones. So cholesterol stones, let's talk about the cholesterol stones. So they are large in contrast with the pigment stones, which are small. They are often solitary, but the pigment stones are multiple. They are yellow-green, and they primarily make up 70% of the cholesterol. So there are 4 F's, if you remember: a female, 40, fertile, fat. So these 4 F is equal to cholesterol stones. So our patient was a female, she was above 40, she had 2 children, and we don't know about her BMI, but we assume that her BMI was high as well. So I hope you are with me. So what we have sort of covered so far is types of stones, pigment and cholesterol stones, their composition, their risk factor associations. So, cholesterol gallstones. So, what's the mechanism of cholesterol gallstones? There's increased cholesterol secretion, gallbladder emptying is impaired, and bile salt that emulsify the secretions, cholesterol, they are decreased in excretion. So, increased cholesterol secretion induces a female pregnancy, obesity, or a weight loss, rapid weight loss in old age, which causes increased cholesterol secretion. Gallstones emptying impaired is if someone is on total parenteral nutrition, if she is pregnant, she is fasting, or the gallbladder stasis, and decreased bile secretion in pregnancy can cause the bile secretion. So some are mixed stones. So mixed stones can be multiple. They can contain the cholesterol, they can contain calcium, they can contain pigments. So 80% of the stones in the chronic cholecystitis are mixed type stones. They are calcium, pigments, and cholesterol. So these three type of things. So there are multiple first degree stones. So clinical features of gallstones. So most of the patients are asymptomatic, and sometimes you do an ultrasound scan of the abdomen for some other reasons, and you come to know that the patient has got gallstones. They are asymptomatic. So most of the gallstones are asymptomatic, which is good news. And few of them, just 20% around, they can cause biliary colic, pain, right hypochondrial pain, acute cholecystitis, or a chronic cholecystitis. So mostly are asymptomatic. Some cause biliary colic and contributes to acute and chronic cholecystitis. Clinical features. So how does it present? Pain is the main feature. Persistence of about 2 hours, sudden happen, and if the pain continues for more than 6 hours, you can think of complications such as cholecystitis or inflammation of the gallbladder or pancreatitis. Pain can be anywhere in the abdomen, but most of the time it's in the epigastric or right upper quadrant. It radiates the interscapular region, but pain can be felt in the left quadrant of lower chest as well. The tip of the right scapula is the main site for the radiation of this pain. So epigastric pain, right upper the vein, differential diagnosis, gallstone, top. So ultrasound abdomen, as we did, it's an investigation twice. Once you have seen the gallstone, then we want to detect the complications of the gallstone, then you can do it with a CT scan, ERCP, or MRCP. Our patient had an ERCP, remember. So asymptomatic stones which were found incidentally doesn't need to do anything. Just leave those stones alone. No surgery. Don't take gallbladder out. Or asymptomatic gallstones. Symptomatic gallstones, best treated with the cholecystectomy. Again, if the stones are giving you pain, if you're getting obstruction of the biliary tree, causing infections, get rid of it. Get rid of the gallbladder. So cholecystectomy, both open oral laparoscopy, oral bile acids, phenodeoxycholic acid or urodeoxycholic acid. The oral bile acids you give, cholecystectomy, bile duct stones, you do an ERCP as spectrotomy and take the stone out. The treatment is different in the gallbladder stone or bile duct stones. Complications. That's very interesting. So 80% are asymptomatic, but when they become symptomatic, they can cause complications. So let's start with the complications. Let's start with the gallbladder structure itself. So what can happen? Inflammation can cause empyema. One type is called a porcelain gallbladder. It can cause biliary duct stones. The stones can pass through the biliaries, can cause obstruction, can cause acute pancreatitis, can cause fistula formation, inflammation of the common bile duct. It can cause gallstone ileus, and sometimes it is associated with the cancer of the gallbladder as well. So it's pretty much sort of a nasty problem if it causes symptoms or if it can cause severe complication. So that's why if you are asymptomatic, don't do anything, but you should start symptoms, get rid of it. Earlier you get rid of it, the lesser chances of the complication. If the complications develop, you're in trouble. So let's talk about all acute cholecystitis. Is acute cholecystitis associated with obstruction of the gallbladder neck or cystic duct by a gallstone. So acute cholecystitis happens when there is an obstruction, the flow of the bile, when there is obstruction to the gallbladder neck by a stone, then there is a stasis, and then there is inflammation. Obstruction can be caused by a stone, by a biliary tumor, by mucus, by worms, anything can cause obstruction. Just imagine the gallbladder is neck, funnel down. Caliber is small in the neck as compared to the face. Pathogenesis is not clear. Initially, inflammation is chemical induced, which leads to gallbladder damage, and it releases phospholipase, some biliary lecithin and lysolecithin enzymes and mucosal toxins. So basic inflammation happens, which leads to gallbladder damage by some phospholipase converting lecithin to lysolecithin, which is a mucosal toxin. Clinical features, as we discussed before, it's the pain in the right upper quadrant, or right hypochondral, variate the scapular region. Murphy's sign, right hypochondral abdomen slightly worse on rigidity and inspiration. With a gallbladder mass you can feel, patient can be febrile and can have leukocytosis. Our patient had leukocytosis, but she wasn't febrile, it wasn't mentioned. So let's try to go through again. Clinical features, so pain in the right upper quadrant, so pain in the epigastric and pain in the right shoulder taper in the scapular region. Murphy's sign, right hypochondral tenderness, leading to reverse inspiration. Gallbladder mass, fever, and leukocytosis. I wish I could ask any questions here, but the system doesn't allow me to ask questions from you or to communicate or interact with you. From investigation's point of view, you do CBC, you will see a peripheral blood leukocytosis. You do LFTs, which are minor vitamin transaminases. MLAs can be done to detect acute pancreatitis. Plain X-ray abdominal chest can see the radiopaque stones, the calcium stones. Ultrasound detects gallstones, and CT can detect complications. So you start with the blood investigations. To rule out a pancreatitis, you do MLAs. To see liver enzymes, LFTs, and with CBC to see leukocytosis. Diagnostic imaging includes the X-ray abdomen to see the radiopaque stones, ultrasound, and the CT. Management. So bed rest. Patient is in pain, you give pain relief, which is NSAIDs and opioids. Be aware of the NSAIDs if they've got a renal dysfunction. Antibiotics as are pseudomonal antibiotics, so third generation antibiotic and metronidazole, intravenous fluids and nasogastric aspiration. So you give the bowel rest, NPO, nil paraoral, intravenous fluids, pain and pain relief. Surgical, urgent surgery is optimal treatment. A patient should be carried out within 5 days of acute symptoms. If cholecystectomy is difficult to perform, ensure subsequent cholecystectomy 4 to 6 weeks later. So you train the gallbladder till you arrange for cholecystectomy. Chronic cholecystectomy. So acute cholecystitis persists and changes into acute chronic cholecystitis, which means that frequent attacks of abdominal pain, often at night and presently by the heavy meals, which could be confused with a peptic disease. Other clinical features can be similar to cholecystitis. Patient can be febrile with leukocytosis. Management. Patient could recover spontaneously with analgesia and antibiotics, or you just give the patient a time or set date for a laparoscopic cholecystectomy. So patient can resolve, can have the symptoms resolve spontaneously. You give analgesia, give antibiotics, and you prepare the patient for elective cholecystectomy. Let's do another case study. Okay. 37 years old woman, 2 children, endometriosis woman, past medical history. She was transferred from some other hospital to our hospital for abnormal liver function test, and she had a common bile duct stone. So fertile, 37, endometriosis, a common bile duct stone because she was investigated for abnormal liver function test. She had intermittent right upper quadrant pain for the past 1.5 years. Previously, outpatient investigation was done. She pain was dismissed as musculoskeletal. She complained of 2 days of persistent right upper quadrant pain with nausea and loss of appetite. So she was nauseated, persistent right upper quadrant pain with nausea and loss of appetite. Examination. She was jaundiced, non-distended soft abdomen, some tenderness in the right quadrant, and she had a positive Murphy's sign. Bilirubin was high, direct bilirubin was raised, she had obstructive pattern. Alkaline phosphatase was minimally the upper normal limit. ALT and AST was raised 6 times to the normal. Common bile duct was dilated in a CT scan, and there is a filling defect which is consistent with the bile duct stones. So this is cholelithiasis. She had 9 millimeters of stones, and she had a pericholecystic inflammation compatible with the diagnosis of acute cholecystitis. So she had a dual pathology. She had an acute cholecystitis, inflammation of the gallbladder, secondary to the common bile duct stone. So she had an ERCP. Large obstructive stone was removed. Spectrotomy was performed, and a basket guided removal was performed to fragment the stone into 3 large parts and remove it successfully. So that's how you do. You do an ERCP, you do a biliary spectrotomy, and you put a balloon through, and a basket guided removal was performed after fragmentation of the stone. The stone was big. So let's summarize this topic of the cholelithiasis. So again, Can be totally asymptomatic. It can cause obstruction, so you expect the features of obstructive jaundice, high bilirubin, pruritus, dark urine, jaundice, pain in the right upper quadrant, and fever. So it could be asymptomatic, pain in the right upper quadrant, fever, pruritus, dark urine, and jaundice. Investigations, well investigations show notice that abdominal ultrasound and dilated extrahepatic inflammation depths endoscopic ultrasound. Yeah, that's the MRC. So, in management wise, give analgesia for the pain control, give intravenous fluids, broad spectrum antibiotics, cover the metronidazole and spinosporin, decompress the biliary gastricity, stone removal, decompress the biliary ERCP, biliary sphincterotomy, and stone extraction control. If ERCP fails, what you do is you transhepatic percutaneous drainage. Give a short wave necropsy, or you can do so. Let's go through the management again. Analgesia, intravenous fluids, cross-spectrum antibiotics, allergen decompression, free of stone removal. I hope you can hear me now. Right, I was told that there was a problem with the voice. So, with management, analgesia, intravenous fluids, broad spectrum antibiotics such as spalosporins and metronidazole, the decompression of biliary tree and stone removal. If it fails, it fails. You do a percutaneous transhepatic drainage, damage. And lithotripsy and surgeries are also options. So recurrent pyogenic cholangitis. So it's the calcium bilirubin concretions, the calcium pigment concretions, and stones which accumulate inside the liver, intrahepatic bile ducts, causes secondary bacterial infections. So this is a cholangitis type of picture. It causes recurrent attacks of abdominal pain with fever and cholestatic jaundice. So this is a biliary cholangitis. So what causes it? It causes by the concretions which accumulates in the intrahepatic biliary ducts. So investigations of biliary tree, you will biliary demonstrate that both the intra and hepatic and extrahepatic portions are filled with soft biliary mud, which are the concretions. It can cause liver abscesses, scarring, biliary cirrhosis. So it's quite significant problems it can cause. This recurrent pyogenic cholangitis. They're treated with antibiotics. So it is a stone, you take the stone out, you drain the biliary tract, and sometimes you have to partially reset some damage areas of the liver. So a few words for carcinoma of the gallbladder. So it's not a common tumor, good news, mostly in the females and elderly. So most common cancers are adenocarcinoma, but fewer are anaplastic and squamous as well. But mostly they are adenocarcinoma. Gallstones are heavily associated with carcinomas, 80% of the cases. The calcified gallbladder is a picture, can present as a gallbladder polyp over 1 centimeter size. Chronic infections with typhoid can cause it. Polyps can change into carcinoma. Calcified gallbladder can change into carcinoma and gallstones. So how does it present? It presents with the repeated attacks of the biliary colic, jaundice, weight loss, and gallbladder palpation because gallbladder is large in the right hypochondrium, which could be mistaken for the liver. So LFTs are deranged, you do ultrasonography, and you do a staging CT to see the spread of the cancer. The treatment is surgical excision. So investigations, blood investigations, of course you do CBC, you know, the routine investigations, but main investigations are LFTs. And in imaging, you do X-ray diagnostic by ultrasound scan, followed by a CT staging. Okay. Another case study. A 56-year-old female with no prior medical conditions, fit and well. 2 months history of upper abdominal pain. Routine hematological and biochemical tests include complete blood count, renal function, LFTs, they all are unremarkable. What the hell? Why we are discussing it here in the liver class, the gallbladder class, and the biochemical tests are normal. So she had very upper abdominal pain with 2 months. No history of weight loss, lymphadenopathy, fever, malaise, pains. Stomach examination was unremarkable and nothing is suggestive for metastatic or paraneoplastic manifestations. So investigations were done. So abdominal ultrasound revealed the presence of gallbladder calculi and a fundic mass which was further investigated. The mass in the fundus. So MRCP was done and it showed the primary gallbladder tumor. There were some gallstones as well. Then she had a staging CT, which excluded any distant hematogenius metastasis. So there's nothing abnormal on biochemistry, there's nothing abnormal on LFTs. Patient had a right upper quadrant pain with a weight loss history, no weight loss history, and she had neoplasm. So surgical interventions included took the gallbladder out, and they proceeded with the staging laparoscopy, and took the lymph nodes out as well. The tumor was removed without any complication. The Palencia Carcinoma, uncommon tumor anywhere in the biliary tree. Again, sclerosing cholangitis, whether it's a primary or secondary, can cause Palencia Carcinoma. Caroli's disease, chronic liver fluke infections, gallstones, choledochoric cyst, they all can cause cholangiocarcinoma. Presentation: upper abdominal pain, weight loss, obstructive jaundice. So obstructive jaundice means there is a disturbance in the flow in the biliary tree, abdominal pain, possibly biliary colic, and weight loss. You do investigation, CT scan, MRI scan, ERCP, fine needle aspiration biopsies, and CA19-9. That's a tumor marker. So you excise the extrahepatic biliary tree. Either you do the resection of the liver or not. Stent can insertion into the malignant biliary structures to increase the bile flow, to decompress the biliary tree, and as a consequence, the obstructive jaundice can be relieved. So, let's go through a case study. Asymptomatic women, diabetic, hypertension, lipidemia, metabolic syndrome, basically. She had previously reported cold and numbness in the upper and lower limbs. No family history of diabetes or cancer. She was 61 kg weight. BMI was reasonable. Blood pressure was normal. She was not jaundice or icterus. She had trace of glucose, and OGT test was abnormal. Patient was maintained on antihypertensive medications with antidiabetic, with a lipid lowering, with some antiplatelet, and her hemoglobin A1C remained 6 to 7 for 2 years. However, her hemoglobin A1C shot up 8.9. Her fasting plasma glucose was 200. Liver functions were abnormal. AST, ALT raised. Gamma GT was in 1000. Bilirubin was raised. MLAs was mildly raised. So she has an abnormal liver function, abnormal glucose, and her diabetes control was becomes abnormal. A plus BC was negative. Tumor markers were elevated. CEA was 7.9. Ultrasonography showed dilatation of intra and extrahepatic bile duct with a common bile duct with no gallstone. So she had an ultrasonography done which showed extrahepatic bile duct dilatation and intrahepatic bile duct dilatation with a common bile duct dilatation with no gallstones. CT scan showed a mass distal to the dilated CVD. Other features were normal. She had an ERCP with MRI, which confirms the biliary duct dilatation and obstruction of the lower bile duct. Endoscopic biopsy was performed, which showed confirmed adenocarcinoma. So she had pancreas was removed, duodenum was removed, and distal bile duct tumor was resected. Histopathology of the resected cholangioma was differentiated with adenocarcinoma, which has invasive in the pancreas and duodenum. So this patient had a metastatic disease or a progressive cancer, cholangiocarcinoma, which invaded the duodenum and the pancreas, that was removed as well. No atypical cells were found in the second gallbladder report. The resection margins were clear. So this is a report of a rare and a unique case in which cholangioma was developed in the distal common bile duct, and the diabetes control was manifested as a hepatic dysfunction at poor glycemic control. So intrahepatic biliary disease, just finish with the extrahepatic biliary disease. Intrahepatic biliary disease, so which can be inflammatory and autoimmune. Caroli's disease, congenital hepatic fibrosis, and cystic fibrosis. So Caroli's disease is a rare, which is a secular dilatation of intrahepatic biliary tree. Extrahepatic biliary occurs dilation also occurs. It can complicate into biliary stones and cholangiocarcinoma. So Caroli's disease is a dilation of the intrahepatic biliary duct, which can cause biliary stones and cholangiocarcinoma in later life. So antibiotic for an episode of cholangitis, segmental liver resection. So take these intrahepatic ducts out and the liver transplantation. Extrahepatic biliary disease presents with the features of impaired biliary flow, fat absorption, and jaundice. This extrahepatic biliary disease is where the gallstone is when the gallstone is consequently structuring of the gallstone passage and such infection post-surgical intervention. Some causes are there. Choledicolocal cyst and anywhere in the biliary tree. There are 5 types of these kind of cysts. So these topics are very rare and they are probably not as important as the topics we discussed before for your professional exam. So cyst anywhere in the biliary tree, a diffuse dilatation of the common bile duct. So there are 5 types, and fifth one is which can merges into the Carolin disease. So these are what exactly it is. 3 and then we start 5. Cyst anywhere is the biliary. So it's a neonatal presentation with jaundice and biliary peritonitis. Excision of the cyst. So that's all for today. Thanks for listening, and I really enjoyed teaching you these topics. I hope you had some understanding and you will be able to build up your knowledge by reading this topic from this. Thank you.